Let's just now discuss about lipoproteins. HDL accepts excess, unesterified cholesterol from cells and also from lipoproteins that have lost their triglycerides and therefore have an excess of surface components, including cholesterol. These are classified according to their density on equilibrium ultracentrifugation. LDL particles can easily penetrate damaged arteries and are mainly responsible for the development of atherosclerosis. HDL particles are the smallest, and epidemiological studies have revealed that high levels of HDL are associated with a lower incidence of atheroma. The larger particles are the least dense and are not atherogenic because their greater size prevents them from passing into blood vessel walls. The removal of cholesterol from artery walls by HDL is thought to be the basis of its anti-atherogenic action. The cholesterol is made less polar by reesterification, causing it to move into the hydrophobic core and leaving the surface available to accept more cholesterol. The cholesteryl esters are then returned to the liver. Let's talk about hyperlipidemias. Primary lipoprotein disorders may involve cholesterol, triglycerides, or both. Secondary hyperlipidemias are the result of another illness, for example, diabetes, mellitus, or hypothyroidism. Hypercholesterolemia is the most common disorder. About 5% of cases are familial, but in most cases, the cause is unknown. The initial therapy for hyperlipidemias, except for severe and hereditary types, is dietary modification, for example, low fat and dietary restriction to obtain ideal body weight. If this fails to lower LDL cholesterol, adequately lipid-lowering drugs are considered, usually a statin. Now let's discuss atherosclerosis. It is not fully understood how atheromatous plaques develop in arteries, but turbulent flow is thought to initiate the process by causing focal damage to the intima. The plaques, which protrude into the lumen, are rich in cholesterol and have a lipid core covered by a fibrous cap. If the cap ruptures, the subintima acts as a focus for thrombosis, and occlusion of the artery may cause unstable angina, myocardial infarction, or stroke. Epidemiological studies have shown a strong positive correlation between plasma cholesterol concentration and coronary atherosclerosis, the incidence and severity of which is greatly increased by other risk factors, including cigarette smoking, hypertension, diabetes, family or personal history of premature heart disease, and left ventricular hypertrophy.